Okay.
Now?
Okay.
Today my topic of presentation is administration of growth factor for HPC cell mobilization and for post-transplant hematopoietic cell reconstitution. These points will be covered into 2 days. What is hematopoiesis? It is production of all type of blood cells, including formation, development, and differentiation of blood cells. These are the different stages of hematopoiesis can be seen. There are cytokine, which like GCSF, L-trombopag, romiblostium, erythropoietin, and chlorhexa. Hematopoietic progenitor cells. All blood cells are derived from the hematopoietic progenitor cells, which like the capacity for unlimited self-renewal and the ability to differentiate into all types of mature blood cells, starting from the common myeloid or the common lymphoid progenitor. Where do we find HPC? They are found in the bone marrow of adult and children, which include femurs, hip, ribs, sternum, and other bones and cord bloods. Type of HPC collection. There are different ways of collection such as bone marrow, peripheral blood cells, stem cells, cord bloods. Among all these sources are bone marrow rich in progenitor cells. These are the picture of bone marrow harvest in which we collect bone marrow usually from iliac crust. These are the picture of bone marrow collection. These are the apheresis machine by which collect the bone marrow. The bone marrow remain the performed source of stem cells for allogeneic transplant disorder, which do not require graft versus tumor. Hello, sir. Hello. Hello.
Yes, we are there.
Yes, we can hear you. We can hear you.
Okay, sir. Okay, sorry.
Go ahead.
Tumor effects. For example, aplastic anemia, sickle cell disease, or metabolic disorder. However, this process needs general or epidural anesthesia, and there is a risk of infection, bleeding, on bone damage. What is the role of growth factor of hematopoietic cells as stem cells transplantation? Type of hematopoietic growth factors. There are different types of hematopoietic growth factor like granulocolony stimulating factor, GCSF, L-trombopag, romiblostium, erythropoietin, and chlorhexa 4. Granulochloroclone stimulating factor, GCSF. Most commonly, we use GCSF. It is a biosynthetic hematopoietic agent which are used firstly proliferations and differentiation of neutrophils within the bone marrow and other sites, example, spleen. Secondly, HPC cell mobilization. Thirdly, post-transplant hematopoietic cell reconstitution. HPC mobilization. Administration of hematopoietic. So there are HPC mobilization is administration of hematopoietic kinases such as GCSF, chemokinesis causing transient increase of HSC is the peripheral blood stems and enable the collection of adequate number of peripheral blood cell source for transplantation. The different method of HPC mobilization chemotherapy or filgrastim plus chlorhexa. Advantages of filgrastim alone is that long toxicity, outpatient administration, high efficiency in most patients, bone marrow, low stem cells yield compared to filgrastim plus chemotherapy, short time from administration to collection compared to filgrastim plus chemotherapy. From nursing care point of view, during the donation procedure, we should be particularly aware of factors that influence risk for donation, which includes age, gender, low weight, duration of procedure, type of anesthesia, CD34 plus cells dose required, vascular access. The role of CD34. CD34 is the indicator most frequently used in clinical practice to determine the extent and deficiency of peripheral blood stem cells collection. Standard target level can vary among treating center, and a patient's specific goal is based on the underlying disease, the source of stem cells, and the type of transplant is to be performed. Target level of 2 multiply by 10 to raised by 6 CD34 plus cells per kg recipient body weight is considered the minimum for
Sorry,
transplant.
Saira. Can you all
Yes,
switch off your microphone cover it, because there's a lot of background noise. Okay, thank you. Go ahead, Saira, sorry.
The role of CD34 cells. A target level of 2 multiplied 10 to raised by 6 CD34 plus cells per kg recipient's body weight is considered the minimum for transplant, with optimal level being greater than 5 multiplied 10 to raised by 6 CD34 plus cells per kg for a single transplant, and greater than 6 multiplied 10 to raised by 6 CD34 plus cells per kg for a transplant recipient. According to JACIE, each nurse should have specific training competence to administration growth factor. GCSF priming in HSCT donor. We use GCSF for priming in HSCT donor. For priming, GCSF give for giving 5 days, prime to BMT in donor to increase the cell count for collection of good cell dose. Start from day 5, day -5 till day -1. We do fresh CBC of donor before harvest, and CBC count, white blood cells count is less than of required dose, we give more dose of GCSF in morning of harvest day. Acute side effect associated with bone marrow donation. Common 20 to 85% of donation: fatigue, collection site pain, back pain, sitting, nausea, sore throat, headache, emesis, IV site pain. Less common, greater than 20% of donation: fever, bleeding, unexpected hospitalization, minor infection, hypotension, urinary tract infection, post is spinal headache, and serious complication 1% of donation: seizure, bacteremia, abscess, prolonged pain or numbness, neuropathy, life-threatening or incapacitating complication. Myocardial infarction, anaphylaxis, prolonged paraphylaxis after anesthesia, pulmonary embolism, transfusions complications, renal failures, and severe stroke and severe pain. Benefits of GCSF prime bone marrow. We can use bone marrow without priming, but there are more different of GCSF, such as First engraftment example, faster neutrophil and platelets recovery. Low incidence of very severe GVHD and TRM. Low incidence of leukemia relapse. Post-transplant hematopoietic cell reconstitution. To reduce the incidence severity, to reduce the incidence severity and duration neutropenia associated with the chemotherapy, cancer patient receiving myelosuppressive chemotherapy, patient with severe chronic neutropenia, cancer patient undergoing peripheral blood progenitor cell collection and therapy, cancer patient receiving bone marrow transplant, GCSF priming, preparations. This is the preparation linograstium, filgrastium, and lipigrastium. Linograstium is a prepared 100 microgram and 250 microgram. Filgrastium is preparation 300 microgram per ml and 600 microgram per ml. Filgrastium roots. Root subcutaneous IV injection by availability 60 to 70%, pack serum concentration 4 to 5 hours, half-life 3.5 hours, binds directly to GCSF receptors and neutrophils progenitor target cells surface and a stimulator neutrophil proliferations. Increase lymphocyte and monocyte count, but does not affect as eosinophil or basophil count. Drug interaction can interference with activity of cytotoxic agents. Do not use 24 hours before or after cytotoxic agents. Storage refrigerator at 2 to 8 degrees centigrade, 36 to minus 46 Fahrenheit. Do not freeze. Avoid shaking. Dilution of filgrastium. If required, filgrastium may be dilution in 5% dextrose. Filgrastium diluted to concentration between 5 ml and 15 microgram per ml should be protected from adsorptions to plastic materials by the addition of albumin to a final concentration of 2 mg per ml. When diluted in 5% dextrose or 5% dextrose plus albumin, filgrastium is compatible with glass bottle and polyethylene IV bag and polypropylene syringes. Do not dilute it with saline at any time. Polyfillating syringes. These all polyfillating syringes are latex-free and contain no rubber or silicone. The plastic plunger has a smooth draw and a positive slip. Syringes are individually sterilized strip package. Polyfine IV bag. Doses and administration. Doses and administration is individualized according to the patient clinical course and average neutrophil count. 5 microgram per kg body weight per day as a single daily dose by subcutaneous injection or intravenous injection over 15 to 30 minutes. Patient with severe chronic neutropenia, initial dose 6 microgram per kg per body weight twice daily by subcutaneous injection. According to JACIE, Administration of mobilization agent shall be under the supervision of all licensed healthcare professional experienced in their administration and management of complication in person receiving these agents. Explanation, administration of hematopoietic cytokinesis such as GCSF is not free from side effect. There are reports of serious morbidity and mortality among recipients of the hematopoietic growth factor. A licensed healthcare professional who is trained in dealing with complication of GCSF must supervise its administration. Common side effect of filgastrium: nausea, vomiting, skeleton pain, tenderness and redness at the site of injection, diarrhea, mucositis, anorexia, headache, cough, skin rash, fever, chest pain, sore throat, stomatitis, constipation, fatigue. Nursing implication. Assessment and drug effects, patient and family education. Assessment and drug effects. Lab tests obtain a baseline CBC with a differential and the platelets count prior to administration drug. Obtain CBC twice weekly during therapy to monitor neutrophil count and leukocytosis. Discontinue filgastrium if absolute neutrophil count associated 10,000 mm per square. Monitor patient with pre-existing cardiac condition closely. MI and arrhythmia have been associated with a small percent of patient receiving filgastrium. Assess degree of bone pain in patient. Patient and family education. Report bone pain and if necessary to require analgesic to control pain. No, proper drug administration and disposal is important. Sir, any questions?